welcome to the 7th and final session of Hand Therapy Essentials, which is being brought to you by the Hand Education Committee from AO North America. My name is Chaitanya Mudgal, and I've had the joy and the honor of being the chairman of this committee over the last 2 years, and I'm coming into my last year. Along with Rebecca Neiduski, who is my co-chair for this particular series, I'd like to welcome you to this final session, which is the International Roundtable, and it is going to be superb. Our AO North America Hand Education Committee has put out nearly 53 webinars or 54 webinars over the last 14 months, a trying 14 months, but we have managed to remain the leaders in hand surgery education across the world. We have included hand therapists in almost each and every one of those webinars, something that no other organization has replicated. And I think that tells you how we value our hand therapist colleagues. All these, in fact, are also freely available on YouTube. Now, my co-chair for this series, Becky Neiduski, does not need any introduction, but she and Kiran Agarwal Harding are going to be chairing this particular session. Kiran is one of our superb residents from the Harvard program, and he'll be graduating next month, or in fact this month, and heading off to Colombia to pursue his hand surgery fellowship. They have a wonderful panel of guests from Sub-Saharan Africa, South Africa, Guatemala, Colombia, and Argentina. I'm not going to take up any more time, but I promise you're in for a treat. So Kiran and Becky, all yours. And thank you very much to all our participants.
Thank you, Dr. Mudgal. It's been a complete privilege and pleasure to co-chair this series with you. And I'm just so excited for this 7th session. I hope that you're all ready for this wonderful evening with really just great contributors from all over the world. And so what I'll do is some quick introductions. Our hand surgeons for this evening, as Dr. Mudgal said, Dr. Kiran Agarwal Harding from Harvard. Dr. Jorge Barreto is coming to us from Argentina. Dr. Linda Chocoto is coming to us from Malawi. Dr. Aida Gomez is coming to us from Bogota, Colombia. Dr. Jay Bridgman is one of our hand committee members, and he's with us today from University of Missouri in Columbia, Missouri. And Dr. Hatim Hamad is coming to us from the Sudan. And so as you see, we've got people truly representing all spaces all over the world. It's so exciting. And then from the therapy perspective, Gretchen Bachman and I will be moderating from the US tonight. Audrey Kronya is here from South Africa, as well as Coriana Van Velze, who's also from South Africa, from Pretoria. And then Marta Beatriz Pinedo Molina is joining us from Guatemala this evening. So some quick housekeeping. These are the disclosures for the evening. Content validation statement. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. AO North America does not endorse nor promote the use of any product or service of commercial entities. And any equipment used in this course is for demonstration and teaching purposes with the intent of enhancing the learning experience. So if accessing the recording every week, the link will be sent to you via email, but also know that these are available not only on YouTube, but also on the AO North America website. Zoom etiquette, all of your microphones have been muted and your videos have been turned off. And we ask, please, that you use the Q&A box for questions related to the discussion topic, and we will be moderating those and bringing up questions out loud and answering them within the Q&A box. And finally, our learning objectives for this evening. We're going to consider the global need for hand surgery and hand therapy. We will contrast challenges and strategies from hand therapists practicing in resource-limited settings. We will gather perspective from hand surgeons in resource-limited settings. We will affirm what hand therapists and surgeons in resource-rich settings can learn from hand therapists and surgeons in resource-limited settings. And we will consider how we can make care better for everyone by considering care delivery for our poorest patients. And with that, I will stop sharing and ask Dr. Agarwal Harding to take over from here.
Thanks, Becky. So I'll go ahead and share my screen here. So hi, everyone. My name is Kiran Agarwal Harding. I lead the Harvard Global Orthopedics Collaborative, and I'm really pleased to serve as a resident member of the AO North America Hand Education Committee. Today, we really have a wonderful panel of speakers, so I don't want to take too much time. This is really to hear their voices, not mine. But before we begin, I'll just take a few minutes to frame this session by talking briefly on the global need for hand surgery and therapy, inequities and burden of disease and access to care. You guys can all see my screen, correct?
Yes, we can.
Thanks, Becky. I have no conflicts to state. So let me begin by stating what is perhaps especially obvious, particularly for this audience. The hand is essential. We use our hands to feed and groom ourselves. We build homes, grow food, create art, communicate with each other, care for one another, all with our hands. For most people around the world, their hands are their livelihoods. And for many poor and vulnerable people around the world, these livelihoods are the only thing keeping them out of poverty, hunger, and despair. Perhaps because we use our hands so much, hand injuries are extremely common. Hand and wrist trauma represent almost 1/3 of the injuries we see in emergency departments in high-income countries like the United States. But what about the rest of the world? So what is the burden of hand pathology in low and middle-income countries? Unfortunately, we don't really know. What we do know is that low and middle-income countries, most of which are in Latin America and the Caribbean, Africa, and Asia, these countries see disproportionately more trauma than high-income countries like those in North America and Europe. In fact, the incidence of injuries in general is rising worldwide, mainly because of a disproportionate rise in low and middle-income countries. It's pushing all of the injuries up, actually. So this is partly due to growing populations in the developing world, industrialization and urbanization, growing number of road traffic injuries, for example. Though few studies have actually quantified it, the evidence does suggest that we're seeing a really alarming rise in the burden of hand and upper extremity pathology in low and middle income countries. And these are countries with health systems that really struggle to meet the needs for adequate care, including surgical care. In fact, worldwide, 5 billion people lack access to safe, timely, and affordable surgery. And this is for a variety of reasons that many of our panelists today will discuss more in detail. But again, we see that access to surgery is disproportionately worse in low-income countries. In fact, over 90% of people in sub-Saharan Africa and South Asia have inadequate access to safe and affordable surgery, compared to just 4% in the US. And this is just surgery. Access to adequate therapy may be even more inadequate around the world. So what can we do about this? In order to build towards MSK Health Equity, which includes adequate access to hand surgery and therapy, there's a lot we have to do. And we almost have to do this simultaneously on all fronts. We have to understand the scope of the problem and the efficacy of our interventions through research. We have to train hand surgeons and therapists and others to manage the burden of disease in the communities in which they serve. We have to advocate to those empowered, those with the funding, for the needs of the poor and the vulnerable. And we have to build the physical and material capacity to adequately manage hand pathology. So in summary, the burden of upper extremity pathology is high worldwide, but disproportionately seems to affect the poor and the marginalized of this world. Access to hand surgery and therapy is inadequate, especially in low and middle income countries, and also for the poor and marginalized communities, even in high income countries. And as an international community of hand surgeons and therapists, we really must address this need. We have to consider it. And education and training can be powerful tools to do so. And that's what we're all about right here, is education and training. So here are a few references just for those who want to read a little bit more about all this. But today we really have a fantastic agenda. We will hear from the perspectives of 3 hand therapists, Adri Cronje, Coriana van Velse from South Africa, Marta Beatriz Pineda from Guatemala, and then we'll hear from 4 hand surgeons, Jorge Boreto from Argentina, Linda Chicoto from Malawi, Aida Garcia from Colombia, and Hatim Hamad from Sudan. And then we'll sort of enter a more informal panel discussion, taking up the remaining time. And so please feel free, anybody in the audience, to write any questions that you may have. We'll try to incorporate them into the discussion as we go. So to begin, I'd like to give the floor to Coriana van Velse. So Coriana, go ahead whenever you're ready. Please take it away.
Good evening, everybody. I'm just going to share my screen. Oh, now I lost it. Good evening. Actually, in South Africa, it's early morning. I'm Coriana van Velse. I'm a hand therapist in private practice in Pretoria, in South Africa. We have very different situations in our country, and I'm in one of the very privileged positions to work in a private practice, but I also work from home, which is very unique. I don't think many people can have a hand therapy practice at their homes. So if you want to have a look at that and what it looks like, go and look at my website, and then you can see what it looks like in my practice. Hand therapy in South Africa is actually very unique because we have three very different worlds that we have to cater for. The private medicine side is mostly in cities and large towns, where the facilities and the staff are of a very, very high standard. And the staff is trained, they're quite experienced, we have good equipment and materials. And language barriers are not that difficult for us because most people who actually have access to private medicine have usually got quite a good command of English, and we can then actually communicate quite well. The resources of the patients are much better. They have money to actually get to the therapy and appointments, and many of them are members of medical aid funds, and that means that they actually are sponsored by the medical aid, or in fact the therapy is then paid for. Then we have government health. Now, government health is particularly in two situations. We have a more urban or city type of government health system where there's a mixture of facilities, but there the staff is very often young, they have limited experience, and the budgets can be very limited, which tells us that the equipment and materials are not that great. There's always a problem with language because the patients who come to these facilities don't need to pay and very often have just not got the command of English or anything that the therapist actually can talk to. So you need to have interpreters, but they are available. If we go to the rural area, it's usually in small towns and villages. They're at clinics. The facilities are usually very, very limited. Staff is minimally trained and not that many. And the language barriers are in a way a little bit less, although they are big because people there don't have any access to English. But the problem is there that the therapists who often, if they're not from that area, also don't speak that language. So they need people to help us there. But Ardi will tell you a lot more about that. So I'm in the privileged position of being in private medicine, but I have got quite a lot of experience in the other situations as well. Why is hand therapy seen is a bit different to resource-rich countries? In South Africa, the types of cases we see, South Africa, unfortunately, has sort of developed into a very violent society. So we have a lot of problems with people with gunshot injuries, knife injuries. We also have quite a few motor vehicle accidents, and also a lot of people are injured on duty when they are working. A big problem is that there's sometimes a large problem between the timing when the injury was taking place and when they actually can receive medical attention. So in that case, even if they get surgery, very often they are very late referrals to therapy as well. And that makes it very difficult because that window of opportunity has been missed. We need to look at low-cost treatment sessions with using tools and equipment, and we'll talk about that a little later. And the big problem here is also the frequency. The people really just can't get to therapy so often, so we rely a lot on home programs, and that means we have to be quite resourceful in our communication. With cell phones and more people owning cell phones, we can actually do video clips of what they need to do. But this is a major, major problem that the patients do not really understand what they need to do at home and how often they need to do it. We use lots of low-cost everyday objects, which I'll show you in the next slide. And we also must not forget how resourceful our patients are themselves and listen to them and see what they can come up with. These are a few of the type of things that I use, even in my high-tech clinical situation. The things like a weight well, which you've seen before, I'm sure. There's just a stick that you can use a weight on and use that as training for wrist movement, or a bag, a shopping bag filled with some weight. I use quite a lot of clamps, and this one is a battery clamp that I've just done. This, I'm not sure if you know this, we call this a vurvur, which is made of scraps of splinting material and a button and thread, And that actually, if you pull it, it sort of makes a sound like a whir, whir sound, which is really quite a funny thing to do. I just want to go back. I've made quite a lot of these very simple type of therapy gadgets, and because they are made for scraps of splinting material, they don't cost that much, so it's easy to give the patient those to take home. As an old-fashioned therapist, I love activity still, so we use games with clothes pegs, elastic bands, and I've just added two very simple slides of splints that you can use, which are very, very low cost. This particular one is a toilet roll stuffed with some sponge and elastics on it, and that really gives a very nice grip for the patient. If we don't have anything else, then we can use that. And this one is a low-cost material splint as well on the right-hand side at the bottom, which is made with wire, scraps of splinting material, and a piece of leather. And because it's a very lightweight but very cheap type of splint, it's also very helpful in situations where the heat is a problem, because in our country we have some very hot places and we need to then look at that as well. Hand therapy in South Africa is very organized. We started very early in the 80s already to get together. The South African Society for Hand Therapists was constituted in 1987. It's open to occupational therapists. Therapists are a member of the IFSHT, and what is very good here is that the postgraduate training in South Africa is very helpful and will make a big difference makes a difference to the quality of care. Unfortunately, the other countries in under-resourced Africa are not that fortunate. And with that, I can actually stop my sharing, and I will hand over to Audrey, who is also from South Africa, and she works in a rural area, which is quite different to where I work. So Audrey, over to you.
Good morning, everybody. Good evening, rather. Morning from us in South Africa. Just want to make sure you can all see my screen. Yes?
Looks good.
Thanks. I would like to talk to you about a rural perspective and practicing OT in a lower resource setting. Lending a hand. Manguvi Hospital is situated in northern Zululand, a 300-bed district hospital servicing a population of 110,000. This series has focused on hand therapy essentials and how the link between hand surgeons and hand therapists is essential in ensuring the best outcome for the patient. I'm fortunate to have partnered with a hand surgeon at a tertiary hospital in establishing a clinic that decentralizes specialist services. In establishing this clinic, it has helped me to improve hand therapy services in our rural area and grow as a therapist. In our area, there are no private hand surgeons, no private hand therapists, and the majority of people have no medical aid and rely solely on the government hospital to access healthcare. The reason we started this clinic was mostly due to the distance from the only specialized hand surgery clinic. The tertiary institution where this clinic is based is Durban, which is a 5-hour drive by private car and a 48-hour plus journey on patient bus. The outreach service was started in September 2016, and mostly soft tissue surgeries are performed. This clinic allows for long-term follow-up with me, the therapist in the rural area, and triage specialist support from a tertiary care center, as well as addressing the other factors listed on the slide that were reasons for the initiation of this clinic. The first case I would like to share with you is a septic hand. Septic wounds is a common diagnosis in the humid climate we experience and very often involve the hand. Mostly these cases are handled by our general surgeon and are always referred early for occupational therapy. This case presented at the outreach clinic, however, unbooked with a very tender, swollen and shiny left hand in a sling. The case was referred via our outpatient department to the operating theatre for an immediate incision and draining. A soft tissue biopsy was ordered and sent to the lab for MCh and to investigate for possible TB. We have a high percentage of immunocompromised patients, and partnered with TB, these two factors greatly delay wound healing. An X-ray was also ordered to establish if there was osteomyelitis. The patient was reviewed on day 2 post in the ward and required further IND. The edema was putting the patient at risk for compartment syndrome, and he required surgical intervention to release the pressure. This case was discussed with the hand surgeon at tertiary, and the general surgeon did the necessary procedures. I splinted the patient in theatre post-surgery in a safe position splint. The following treatment modalities were used to treat this patient while he was admitted: elevation, wound care, splinting, static and serial static and dynamic, manual edema mobilization, passive Maitland's passive joint mobilization, and active exercises. The slide shows some of the low-cost materials and activities used to ensure the hand was used actively in rehab. The second case is a stiff hand. This gentleman had an injury on duty on the 4th of December. His date of repair was the 21st of January at a different hospital to ours. His first visit to Manguzi was on the 20th of February, a month later. The left picture shows his hand prior to surgery. He had 0 degrees of active MCP flexion. He had a capsulotomy performed at our hospital by the surgeon on the 24th of July. Treatment modalities included static serial splinting, static regressive splinting, and dynamic splinting. All the orthoses used were custom made to fit the patient, no off-the-shelf luxuries in my village. This patient regained functional ROM of the MP and IP joints, although it was not full active ROM. In the rural setting where I work, I have used many different low-cost resources to achieve active use of the hand in therapy. I have learned some from Koreana, and I use them regularly. In the case of the stiff hand, the following was used to achieve return of functional use. Adaptations are made to build up grasp during his rehab on his most used tool. He's a carpenter, in this case by upcycling high-density packaging foam. The second is a fine motor skill exerciser. The third, a flexion glove made for nighttime use to improve his composite flexion. The fourth pic shows exercising intrinsics using Play-Doh or Theraputty. And the fifth, a handheld ruler with Velcro attached to either exercise into flexion or extension against resistance, or with a longer lever, pro and supination. My take-home message is that the center of all therapy is the patient, and it is the same in rural. Following the establishment of this clinic, the patient received timeless intervention, surgical and therapeutic. There's minimal financial implication to the client, as the client does not have to travel away from home for surgery. Assisted devices are custom-made and low-cost materials are used as far as possible. Looking at what is available in the client's home or environment is used in a practical way to implement rehab. The patient has access to early rehab, and long-term follow-up is arranged to accommodate the patient. Thank you.
Thank you, Audrey and Koreana, for wonderful presentations. I'd love to ask our therapists to please turn on their videos. And Audrey, since you're coming right off your presentation, I'll begin with you. It's interesting. I know Marta Beatriz is from Guatemala, and the parallels between private practice, governmental city practice, and rural practice from the government are very interestingly parallel, I think, in these two countries. Audrey, can you and all of you, would you just share with us how you address these needs in under-resourced countries? Are there local, regional, international resources, teaching, training that you have found to be helpful in advancing the practice of hand therapy? And Audrey, to your point, really serving the patients in these areas?
Yes, I think the simple answer to that is the decentralization of these specialized services. Bringing a specialist to a rural or low income setting, it costs a lot less and is a lot less effort than busing all the patients to the centralized unit. In saying that, the hospital or the institution at a rural level needs to have a surgery and some form of space for the surgeon to actually perform these duties in. But we have found that to be very helpful, as well as online platforms to kind of have this skill sharing. So in the time of COVID in the last few months, our outreach also has come to an end, and we have definitely used online sharing like Zoom to help skill sharing from the specialists to our surgeons, and as well as having case discussions via these platforms. So I found it very helpful for that. I think Koreana can also mention, or she did mention, that we have really good postgraduate training for therapists. And we have a high rotation of community service officers that need to do a year in a rural setting or a low income setting.
And Andre, I just want to repeat that for the audience. So all of your graduates from therapy programs actually do a year of community service in South
Yes.
Africa before entering their practice. Is that correct?
Yes, you won't be signed off for independent practice if you've not finished your community service year.
Fabulous. Wonderful. Coriana, is there anything you'd like to add from your perspective about really addressing needs in under-resourced areas?
Yes, as Audrey has mentioned, we have a community service system in our country, which is very, very important for everybody. Unfortunately, when our students actually graduate, hand therapy is only a small little part of their actual training. So we really need postgraduate type of intensive hand therapy training, which I think we're not getting enough of. And then we are so much more blessed than so many other countries in Africa. I sometimes feel very ashamed to talk about it and say, oh, but we need a lot more. I think we also don't always understand how often patients are neglected and the sort of cases that we actually have to deal with. And if you're a community service therapist, very often you don't have enough access to mentors. But with technological advancement, many of our therapists at least have computers and they have cell phones, and they can actually now call somebody like me as a mentor and phone up and say, what do I do now? And here is a video clip, which has made it a lot better. But these students all need a lot of training still. And this is where our problem is, that training in a very specialized hand therapy setting is not so freely available. But there is always a situation, and that's probably something that people in resource-rich countries can help us with. But the problem there is that they don't understand the actual extent of the poverty in these rural areas. And this is why we still have a lot of challenges to actually get onto.
Oriana, to that point, I just wanted to ask, what role do you think, if any, South Africa is playing for, as you mentioned, the training of hand therapists like throughout the continent of sub-Saharan Africa?
I've been approached a couple of times to help with training. The problem is really, again, it's easier or much cheaper and helpful if I can fly to another African country and work alongside therapists in their setting, because I think I appreciate their setting more because I understand it better. I've worked in these type of situations. But then the problem really is that they don't have the resources. And I can't just pack up and go and just do everything like that. So financial help is always would be helpful. But then it would also be a good idea if somebody from a resource-rich country has this need to actually get into Africa to see what's happening, is to actually come to South Africa and other African countries and see in which way they can actually make a difference. But I think we have to be very resourceful and not to be there to say, well, this is the way we can do it. We must actually always make sure that we listen to the population themselves and what they are, what their biggest need is and what their priority is, because that's usually a big thing. You get the people flying in from another country and they change the world and they go off again. But then there should be a trained person left behind who can continue. And unfortunately, as soon as you start training people, then they start thinking, well, now I don't need to stay in my own country. I can now go and work in the US, or I can go and work in other places. And then they leave that area. So they're left behind again with very, very undertrained people. And that's probably a very ongoing circle of things that's happening.
Marta, would you like to add anything about teaching and training in Guatemala from your experience?
Yes, I think with Korean, we have a lot of similarities in our countries because we have the same three aspects: the government, the private practice, and the rural work. And as she said, we have a lack of specialties here. I think we have been very privileged because since 2004, we have the missions coming to Guatemala. Every year we have meetings, we have seminars, master classes from Guatemala Healing Hands or Hearts in Motions or Drexel University. And we became 8 of us became specialized hand therapists, but we have a lot of therapists here and we need this education. And I think the best thing I can say is this pandemic has shown us how the virtual education can be. And we have universities very interested in create a program. And because I think even if we can work as a hand therapist here in the city, we need a lot of help inside the country. Guatemala is a very small country with large problems. We have a violence here. We have barriers in languages too, because we have 32 Mayan languages here, and the Spanish. And so that I think education is the main thing we can ask. Mm-hmm.
Thank you, Marta. And Audrey, did you want to add something?
Yes, just to add, in addressing the great need for improved pre-graduate training, as Coriana mentioned, it's such a small part of your training as an occupational therapist to do hand therapy, and it's such a big scope. There's so much to learn about it. What I found very helpful is the decentralized training that has been started in South Africa, where universities actually send students to a hospital to come and do an extensive 6-week block, where they then do all it's almost like on-the-job training, and they really get a feel for what kind of cases they're going to be seeing, how to manage difficult cases, and it's just a practical way of really just almost like hit the ground running when you then do qualify as a therapist, because you actually have seen it. And a lot of students have let me know that that's actually been so helpful in their training, because when they've seen these things before. It's not brand new. They kind of know what to do and manage, but like also an improved mentorship program is really also one of the things that I think will be helpful, that could address this need.
The value of immersion, right? Of bringing the students in early, getting them excited and passionate about hand therapy, but letting them stay with you for 6 weeks to really see what the practice looks like and feels like. I think that's such a great suggestion. Well, I think with that, Marta, I'm going to ask you to go ahead and share your slides and share your case with us. Marta Beatriz Pineda Molina is the president of the Guatemalan Hand Therapy Association and was one of the founders, actually the founder of it. So Marta will share some case with us from Guatemala.
Let me see. Hello, everyone. I am going right away with my case. This is a male patient, 35-year-old. He's a computer programmer, and he had an accident with a knife in the night of New Year's Eve. His dominant hand is the left one. He had a rupture of the fifth finger. He had a rupture of the FDP and FDS, and the fifth finger, left hand, zone 2. And he had a tendon repair. So you can see the injury there. Then this surgery was performed by Dr. Victoria Choquin, who is one of the 2 female hand surgeons in Guatemala. She sent the patient 8 days after the surgery. And that was really good because we are not used to see the patient at that stage. In the office, I changed the bulky dressing and I made this flexor tendon orthosis. And I taught the patient how to move passively in flexion and extension to maintain the range of motion in shape. Then after some weeks, we start to move actively, but I noticed at that time that the FDP wasn't moving properly. So I made another orthosis, blocking the MP and the PIP, and promoting the motion of the FDP by exercises and using NEMS as a feedback. And we keep on working, and then the result of the patient is this one. After a lot of things to do after a lot of things to do, working with another kind of things we have every day here, rice and beans, and even curlers to work with some relative motion. Excuse me. Then how we can provide care to the poor. I put these two pictures because they are very, very important for the topic we are talking about. This, we have in Guatemala 17 hand surgeons, 8 specialized hand therapists, and we have this large portion of physical and occupational therapists. These are very important because since 2004, when we are having meetings and seminars and everything I was telling you before, the crowd we have in every activity is this crowd you are seeing at. That means that we need education. Therapists want education. All of them are occupational and physical therapists. So then the best way to take this care to the poor, and not only the poor, but the people who can't have the chance to find a therapist nearby, is educating these therapists, because all of them are working all around the country, in places very, very far from the city, and educating them is the best thing we can do. But we don't have academic degrees. So I think we can make something to have them in the future. And this is all I'm going to say for now. So I'm sharing. Okay.
Thank you so much, Marta. That was fantastic. And I think we've had a really great discussion already about a lot of these issues. I want now, just for the sake of time, to move on to Dr. Linda Chikoto to start hearing the perspectives also now from hand surgeons, which I think will be very helpful to frame our discussion. So Dr. Linda Chikoto is a hand surgeon from Malawi. Linda, whenever you're ready, go ahead and share your screen and take it away. Linda, you're muted. You want to unmute?
Hello, can you hear me now?
Yes.
So, hello everyone. I am Linda Chikoto from Malawi, as already introduced. And in my discussion, I'll talk a bit about Malawi and the background information on the health system before I talk about the hand surgery in Malawi. So Malawi is a country that is in the southeastern part of Africa, bordered by Mozambique, Zambia, and Tanzania. A third of the country is occupied by the lake, and there are a lot of species of cichlids and other sporting activities that happen on the lake. And we also have the Big Five, so you're very welcome to come to Malawi anytime. It has a population of 18 million people, 80% of which are rural. And also important to mention that healthcare in all public hospitals is free. Patients do not pay for any services. The healthcare system in Malawi has 3 tiers. The primary healthcare and the secondary healthcare are all predominantly rural. And in all these facilities, they are only non-doctor personnel who provide care after they have had their training for either 2 years or 3 years after secondary school education. And in some centers, they are nurses who provide primary care. Now, the central hospitals, they are all in the urban areas, in the cities, and this is where we find the specialist surgeons. And in Malawi, currently, we've got 15 orthopedic surgeons in the whole country and 3 plastic surgeons. Now, there are some challenges that are faced by hand surgery in Malawi. The first one is that we've got too many road traffic injuries. As a result, we tend to get quite severe hand injuries. We also have quite a significant proportion of infections, and some of these infections present quite late. Neglected cases, we see quite a number of neglected cases. And as I said earlier, the majority of the population is rural, and therefore their care is provided in the rural facilities, in the primary and secondary care facilities. And because the people providing care in these facilities have not had enough training in hand surgery, we tend to see quite a lot of missed cases. This was a case of missed ulnar nerve injury, which presented 5 months later. Inappropriate management of cases for the same reasons as outlined, but also low priority given to hand surgery cases. I will discuss this case later on, so I'll give a bit of details. We do not have enough rehabilitation services. Most of the population that are in rural do not have access to physiotherapy. We do not have any hand therapists in Malawi, but even for those facilities that have physiotherapists or occupational therapists, they are very few and therefore not accessible to the majority of the patients. And we also have problems where people present very late with very complicated cases such that it is very difficult to do anything about it. So what's the future? I think the most important thing that we should concentrate on as Malawi is to have instructional courses. And these courses should include really rehabilitation as well. So our care providers, because we do not have hand therapists and because most patients do not have access to physiotherapy, I think the most important thing to do is to train the primary care providers in some of the therapy, not just in training them to manage hand cases, but also to provide some therapy, and also establishing hand surgery clinics in the central hospitals, which can act as training centers. So really the take-home messages is that Malawi is faced by a lot, hand surgery in Malawi is faced by a lot of challenges. We need instructional courses, and these courses are really twofold. Just for instance, training surgeons and trainees, but also training the majority of the primary care providers. And there is need for hand therapy training, even in our rehabilitation assistants, physiotherapists, and occupational therapists. Well, now I'll go on to discuss a case which is an infection after trauma in a 47-year-old man who was attacked by robbers at his house. He sustained extensor tendon injuries and had also an open fracture of the index finger. He was initially taken to theater for debridement and was then supposed to be reviewed after 48 hours. But then when he went back to theater after 48 hours, he had to be sent back because there were other cases that were felt to be more urgent than his case. So a second look after 48 hours was not done, but the wound was then opened after 72 hours, and this was the condition of his hand. He had developed necrotizing fasciitis. And you can see it took a lot of debridements and vacuum wound dressings to get him to this stage. This is the final outcome. And it just shows how this is the trend, not just for him, but for most hand cases, the attitude that it's just a hand is quite common in our setting. Unfortunately, he lost the index finger. We could not save it, but this is the final outcome. Thank you.
Thank you, Linda. That's a very challenging case, and I think you've done a really nice job sort of demonstrating what the circumstances are in Malawi that lead to complex cases like that. I'd like if Audrey and Marta could turn on their cameras and maybe comment a little bit about this case. Are similar situations things that you guys see in your practice setting? What is some advice that you would give to, these general physiotherapists that must manage the kind of cases that Linda just presented? Marta, maybe we can start with you.
Well, I think there are very similar cases in Guatemala too. And we don't have the chance to go inside the the OR very, very often, but I think the best way is that she said is sending the patient right away to the therapy, so we can help more to recover soon.
Yeah, the issue in a place like Malawi is that many times these therapists aren't available. Is that right, Linda?
The therapists are not available. Yes, that's the main issue. So in facilities like in central hospitals where we do have some therapists, I think it was Audrey who mentioned that sometimes it takes so long for the patients to come to the therapist because the therapists are overwhelmed. And so they will give a booking date, which is like a month after when they were supposed to get their initial therapy. So we do have a problem of lack of therapists, but in cases where we do have therapists, the therapists are not hand therapists, they're just general physiotherapists or rehabilitation technicians, which is a cadre lower than physiotherapists. They are such that they don't have the capacity to do timely appointments with the patients.
And Audrey, is this something that you've dealt with? Have you found a way of working with folks who may not have your level of training, but have to manage sort of complex cases like what Linda just presented?
Yes, I think we have a very similar situation in South Africa, but again, we are under-resourced, but more resourced in Malawi, sharing knowledge and skills via the Vula app or platforms like Zoom. We do a lot of phoning a friend, if I can call it that. I hear what Linda says in terms of there are no therapists, but the primary healthcare practitioners, which are your nurses, I believe very strongly in working with them. If your nurse is on the ward, knows about wound care and wound healing and timeframes and really just how to look after that hand initially and what's going to be important, I think education with your nurses post-surgery is also very helpful in managing the stiffness and all the complications that come with that. We also have a high caseload of necrotizing fasciitis, and they are very challenging patients to treat, just due to the extent of the damage usually and the soft tissue loss. But I feel if your nurses are on board and you have a strong team, that could be a way of looking at early intervention if you don't have that therapist there. Education is key.
Linda, I think one thing that you had mentioned also was the fact that sometimes patients have trouble even getting to the hospital. So yes, I think, Audrey, your point is well taken that getting nurses to, any level of health practitioner to chip into the care of these patients is fantastic. But what do you do in a circumstance like in Malawi where patients can't even get to the hospital? That's even more difficult. Yeah, go ahead, Audrey.
Do you have community caregivers or people that work on the ground in Malawi that go from homestead to homestead that are do you have anything like that, community-based rehab? They're not necessarily trained therapists, they are just community caregivers.
We do have community caregivers. We call them health surveillance assistants who are, they don't have a proper medical training. They are trained for, I think it's 8 weeks to provide basic care, but it's not for conditions like any surgical conditions. It's mainly for maternal and child health, and malaria prevention, providing malaria drugs, but not for surgical conditions. They do not manage surgical conditions.
Okay, thank you. I've found that even training your health community surveillance, or we call them community caregivers, doing basic in-service on what to look out for, when to refer, what can be done, like just basic training in terms of if you see an infection, what does it look like, what to do. So I find that network very, very helpful in a rural area. Yes, very often we get patients that do need surgical intervention, but they've been picked up by these community caregivers and referred to either their local clinic or their closest residential clinic. So, and I found this network to be very helpful, and a little education goes a long way in trying to, yeah, and helping, I think is my point. They could be.
Yeah, great points, guys. You know, it represents just how much weight is on the shoulders of just so few people, you know, in settings like this. So next, for the sake of time, I'd like to move on to Jorge Barreto, who's from Argentina, a hand surgeon there, who will present a little bit of a different circumstance, working in a hospital that perhaps has far more resources than the kind of hospitals that Linda was just describing. Jorge, whenever you're ready, go ahead and share your screen and take it away. And then after that, we'll hear from Aida from Colombia. Thanks so much, Jorge. Go ahead.
Okay, thank you so much. A minute. Well, hello everyone. Thank you so much for the invitation. I will present a case of single-stage flexor tendon grafting. This is a case of a 16-year-old boy who presented with a 3-month history of a sport trauma of his dominant right ring finger, complaining about the lack of full finger flexion. X-ray evaluation showed no bony injury, yet the initial presentation, he had a quick dash of 7. During the clinical examination, the patient was unable to fully make a fist due to inability to flex the DIP joint. So a jersey finger type 1 avulsion was diagnosed. According to the diagnosis, a single-stage grafting was proposed as a treatment. At the preoperative examination, a passive full range of motion of the ring finger was noted, and the presence of the palmaris longus as a source of tendon graft was determined. During the surgical procedure, a 2-centimeter incision was made at the wrist crease, and the palmaris longus tendon was identified just beneath the skin. After its identification and distal dissection, the tendon was harvested with the use of a tendon stripper. The distal tendon juncture was done first with a suture anchor to attach the graft to the distal phalanx, and the distal flexor tendon stump was also sutured to the graft. After that, the graft length and the graft tension was adjusted when the proximal juncture was sutured with a pulver tough wave suture, and the tension of the graft was defined after the first pass of the graft through the proximal motor tendon by increasing slightly the digital flexion cascade. During the postoperative period, at the 2nd or 3rd postoperative day, the patient started with a protocol of progressive 4 exercises. The program included a dorsal sprint with the wrist in 15 degrees of flexion. Nowadays, we favor the neutral position of the wrist. Protected passive range of motion is prescribed for patients during the first postoperative visit and continue for the duration of protective splinting. Also, assistive active range of motion and place of whole finger flexion exercises were included during this period. Finally, active short arc digital flexion exercises were indicated, as you can see in these videos. Between the 3rd and the 6th week, the rehabilitation program included the protected dorsal split with a change in the wrist position to neutral. The passive range of motion exercises continue until the 5th week. Active composite fist exercises were prescribed. Finally, external stabilization of the proximal phalanx allowed for DIP and PIP joint motion, while blocking the MP joint and lumbrical function, and stabilization of the middle phalanx allow for DIP joint motion, as you can see in the videos. After the 6 weeks, the protective splint was discontinued. Active and passive full arc of digital motion exercises were performed. Progressive strengthening was obtained by means of resistive exercises such as resistive composite fist and resistive hook and straight fist. This is a result of, at 17 months follow-up, the patient recovered a full finger of his finger with no limitation. In flexor tendon reconstruction surgery, rehabilitation has been shown to be effective in reducing the impact of restricting intrasynovial adhesions, simulating the restoration of the gliding surface, facilitating the healing of the repair site, and allowing more complete recovery of digital range of motion. All of this involving the patient in its own rehabilitation by means of education and compliance behavior. A tailored regimen of exercises, education, and equipment is a distinctive feature of quality rehabilitation in flexor tendon reconstruction. Individualized adjustment to postoperative management should be systematically implemented if rehabilitation exercises are sequenced according to the criteria of internal forces applied across the tendon juncture. A model of progressive therapeutic exercises along the criterion of forces applied across the tendon juncture, considering excursion requirement, are the key point to achieve optimal result in terms of complete recovery of digital range of motion. Well, thank you. In terms of as you say, Kiran, about my hospital work in a tertiary hospital. However, we were challenged last year by the lockdown imposed by the government during this pandemic. So the hand-on treatment delivered by the hand therapist turned into a telemedicine care. While most of the patients could be treated by this new wave of care, the problems we found were related to the accessibility and comprehension of the new technology by the elderly.
Thank you, Jorge. That's really helpful to see. I mean, you know, honestly, seeing your slides here, it's like presenting a completely different world from what Linda has presented. I think I'd like to now invite Dr. Aida Garcia to present her case, just to also show the other perspective from another country in Latin America. Aida, whenever you're ready, go ahead.
See my slide?
Yes, I do.
Okay. So unfortunately, in Colombia, we had been in a war for the last 50 years. And I work at the military hospital, so I bring a war trauma case. This is one of the military nurses doing a rescue. And as you can see it, at the helicopter, he's not protecting at the extremity. So he got shot in the wrist. You can see a severe compromise of the bone part and also soft tissues. So for this kind of patients, we do the management by stages. So the first one is an inventory where we do a debriefing. We have to make sure that it's not infection. And at this stage, the physiotherapist is going to start the work with management of swelling. Also, she will help keeping the joints with movement, passive movement. So it's quite important for us, the work that the physiotherapist is doing since the beginning of the case. After the first stage comes, you can see that here we use external fixation, and it was really important to cover all the lesions. So we do a free flap, and we get it. So we save all the tendon that were exposed at that time. For stage 2 is the repair. So we start with the stabilization using plates, as you can see it over here. Wasn't not too much to do for this carpus, so we do that total arthrodesis, and we start to do it surgeries in order to get a functional hand. So here the physiotherapist is going to start with exercise, with an active exercise in order to get a fit for the patient. The third stage is a reconstruction. So here we have to make sure that the joints are working. So we do tenolysis, capsulodesis. Also, we have to make sure that the nerves are recovering. Otherwise, we will do nerve transfers. In this case, I did a Sobeka Panji in order to get pronosupination but I lose my results, so I have to get it back into the OR and do an ostectomy of the curative to get the movement again, the prone supination, as you can see it at the video. And the fourth, but not the last one, is the rehab. Doesn't mean that it's the last one. This one starts as the beginning, as I already told you, because we need the patient to get with the occupational therapies in order to get normal functions, that grip, to take care themselves. So this is the same patient, and this is the functional that we get it. I know that it's not a normal function because his thumb is static, as you saw at the X-rays, but the function is quite enough to get him to grip things. And we also use dynamic splints during this rehab, because the goal for all the team, for the surgeons and also for the therapists, is to get a functional hand. So clearly it's not a normal hand, but I think it's quite functional for this soldier. So take home message home is for severe trauma management in stage. It allows functional results and also allows to do a good planning of the follow of this treatment, because one of the biggest problems that we have with war trauma are infections. So I have to first make sure that it's not infection in the extremity, and then I will go with reconstruction and all the surgeries. And the physiotherapy is essential from the start, because less swelling means less fibrosis, and that's going to be more movement for this patient. For Colombia situation, well, we are in South America. We have a population about 50 million people, and we are around a little bit more than 180 surgeons for the whole country, and we have around 14,000 physiotherapists. But less than 5% of that group of physiotherapists are hand therapists, because education in my country is really expensive. So sometimes it's really hard for physiotherapists to continue the education to get a new degree in hand therapies. 100% of the population in my country has medical service, basic medical service, but less than 45% of that population have access to a hand surgeon. So at the beginning, when I started hand surgeons 10 years ago, I was a little bit frustrated with my results of my surgeries. And then I was working in a public hospital at that time. So I realized that it was really hard for my patients to get to a general or a normal physiotherapist. So I decided to spend some time with the physiotherapist or the occupational therapist from my hospital in order to learn how to do my own dynamic splints. They teach me, so I decided to make my own splint. That means that I have to check the patient every week and to do the modifications to that splint. But I was really gratified for me because I was getting best results, and my goal for the surgeries was a good functional result for my patient. My hospital right now is a military hospital with a special population, as you saw, our soldiers, and I'm really lucky because I got a great team. Because we have our main problems are war trauma, so that means high energy trauma. It's not just about a bone or fracture; it's about a complex situation. Also with amputation, as you can see it in the picture, the patient have fingers amputation and also the leg amputation. So that means that we have to work as a team to get the patient functional at the end. And in my group or in my service, we have a special group just for hand and upper extremity pathologies with 3 hand physiotherapists and 2 occupational therapists. So it's a great team, and we also are able to use technology, as you can see here in this video, and we're improving with technology. So we're mixing a game with physiotherapies because most of the soldiers are quite young. They're around 20 or 25 years old. So this is a good idea for them. They keep us busy, and also they're doing the physiotherapy at the same time. And everything of this, we are working and we do it really hard just to get a functional hand, like the video. I'll show you. So as a Colombian Hand Society, we have goals. I'm part of the board, and we have three main goals for Colombia, for our country. The first one is to support the education and training of hand therapists. So because the pandemic, right now we're doing virtually, but most of the time we combine our academic program with the hand therapists. Also at the annual Congress, we have a special part for hand therapists. The other goal is to make communication channels between hand surgeons and therapists. So we create a WhatsApp chat where all the hand therapists can ask hand surgeons. They can also show the cases or if they need help. So it's a communication channel and reach the most needed population with humanitarian missions. And that's why for the last 3 years, we have done this mission that we call Manos a la Obra, and we do free surgery for kids with congenital deformities. Thanks.
Ida, thank you. That was fantastic. I mean, I think you covered a lot of the points that have been made by several of our other speakers already. I really, the point about distance learning, improving access to knowledge, working as a team, that was all fantastic. Also, I think the point that I want to hammer home that I really loved was that you picked up the skills yourself to do some of the work as a therapist when you didn't have access to hand therapy directly. And that's, I think, really the purpose of these sorts of webinars is we're trying to do exactly what you did, is try to disseminate some of this knowledge to others. So for the purposes of time, I think I'll transition now to Hatim Hamad from Sudan. Hatim, are you there? Would you like to share your slides and talk a little bit about the situation in Sudan, which is now a little bit of a difference. We're back to Sub-Saharan Africa. Go ahead, Hatim.
Thanks for the nice presentation I have seen now. So I'm going to share my So is it clear for everyone now? Can you see me?
Yes, go ahead, Hatim.
So thank you very much. Now I'm going to talk about hand surgery in Sudan, and I will start with the case presentation in this great roundtable discussion. I'm going to present a lady who is 43 years old, who is working as a nurse. She is a right hand, she is non-diabetic, and she complains of right hand pain and stiffness for 3 months. And she underwent abscess drainage surgery by a general surgeon 7 days after symptoms started. And I think this was a misdiagnosis because no evidence found in the full review of her investigations and clinical data. And her symptoms were getting worse over time. So these are her pictures upon presentation 3 months after the starting of these symptoms. And I will go back to what happened during these 3 months. I just mentioned that she had been treated by a general surgeon to drain an abscess, as you can see here over this strange incision and approach. As you can see, there's some changes, or there are some changes here in her nails and skin, and here her range of motion when she presents to the clinic 3 months, you can see clearly that she's not having a full fist, and she's having pain with all these movements she's doing. These are her initial x-rays. Upon review, actually no bony abnormality showed, and these are the 3 months later x-rays when she presented for the first time to the clinic, and you can see clearly the osteopenia, which is scattered all around her hand bones. After lots of work and investigations, we concluded the diagnosis of pain syndrome after workup, and this is one of the very common presentations in my country because of many causes. I will just mention four. Let me just go back to this. And these are the modalities of hand therapy. So they started to focus on pain relief modalities and getting a range of motion exercises for her with the available resources by our therapists, who are not mainly hand therapists, they are general therapists. And after a while, and lots of support by them and medications, she improved with a marked improvement in terms of pain relief and functional range of motion. And just a note here, the physiotherapy was done by a general therapist. So this will lead me directly to our needs and our problem in Sudan. It was for me to hear from Aida from Colombia right now that there are 50,000 or 50 million people in Colombia, and they have more than 170 surgeons. And the situation in my country is different. We are only 3 hand surgeons and serving about 50 million people. So you can imagine how is this service available for population. So we have lots of challenges. We have, from the therapist perspective, we don't have a single certified hand therapist in our country, unfortunately. And the other problem we are facing are the wrong beliefs that about the physiotherapy and the issue of the traditional bone setters. And this is a belief which is concluded like it's not like something relevant to the economic status of the patient or the financial status of the patient. It's just a belief of professors even and teachers, doctors even, they can go and seek traditional bone setter management as a belief. We have, as many countries in Africa and the world, we have financial challenges. We have the lack of the good integrated public service, which is not available for everyone. We have the problem with insurance, which is not for everyone. And the public service of insurance is not that satisfactory. And we have the private insurance companies which are available, but not affordable to all people. And the other issue of delayed case presentation, as you saw this lady who is a nurse, and she presented 3 months later after she had been operated by a hand surgeon for a drainage of an abscess, which was not an abscess at all. And then she saw like a traditional bone setter, just believe it or not. She was in follow-up with a traditional bone setter for more than 2 months. And at the end of the day, she came to the service, which could be available for her, especially because of her. And as I mentioned, you are only 3 hand surgeons serving 50 million people. So how are we getting this available for population? We are training lots of general orthopedic and plastic surgeons. We started this during the last maybe 5 years, and training hand therapists in collaboration with the surgeon of the hand. And we used the input of the private companies and centers to make this service available for most of the patients. We have lots of charity hospitals that are working but are not covering the whole population service. And again, we are seeking international training opportunities for our therapists and for our surgeons. And we are now focusing on those last 2 points, which are the health education programs for the population and for the we are adopting a community-based medical education in our basic medical and physiotherapy schools, so as to get people involved with the community, so as to get as many of the beliefs and the intervention that we can use in order to solve our problem. And thanks from our country, Sudan.
Thank you, Hatim. Thank you to Linda, Jorge, Aida, and Hatim for showing like really a wide variety of cases and circumstances. But I think that there were some very common themes throughout. There's centralization of certain resources in the urban centers, lack of access for the rural patients. Every country is obviously very different in the level of resources, but lack of trained professionals, lack of resources, actually like the physical resources. And you guys have all illustrated some excellent examples of strategies to address all those challenges in your own settings. I'd like now to actually, Hatim, if you can stop sharing your slide.
Yeah, okay. Yeah, here we are.
Yeah, I think now maybe we can, Becky, I don't know how you feel. Maybe we can transition now to our panel discussion.
I think that sounds great.
Hey, Kiran, can I raise a point?
Yes, please do, Dr. Mudgal.
One of the things that got lost in the presentations was the importance of what Aida said in terms of using WhatsApp. It's a tremendous resource between resource-limited countries and resource-rich countries, where they can seek assistance and in real time be able to see and talk to you and demonstrate things. I use that routinely whenever I operate overseas, and if there's no hand therapist, I'm able to see the patient when they're sitting with the local surgeon and talk them through that. And I think we should really emphasize that as a thing from this, a take-home message from this session.
Yeah, that's true. I think availability of resources like these electronic resources like WhatsApp are really, really critical. Like not only for visiting surgeons like you, but even for local folks and even reaching patients in their homes. Mobile technology has been great, I think. But anyway, so I wanted to kind of share a paper here just as a little bit of food for thought. So this is a really lovely paper written by Santosh Rath in Orissa, India. He works in a facility that mainly manages a large volume of patients with leprosy, which I'd be interested to hear if you guys see patients like this in your settings. So this is a small retrospective case series that he did of patients with low median nerve palsies who lacked thumb abduction and opposition. So all patients underwent tendon transfer to restore thumb abduction, and then half the patients were immobilized for 3 weeks, and then the other half underwent immediate active mobilization with a team of skilled therapists. And the findings of the paper are that this immediate active motion protocol did not alter the final outcomes for patients compared with the immobilization. So no evidence of tendon pullout or anything requiring revision surgery. And in fact, the benefits were that you had reduced rehabilitation time and reduced cost of that time to the individual. So patients, especially in a low resource setting, were able to return to work, get back to agriculture, all the things that were necessary for their livelihoods. So of course, the success of this immediate active motion protocol requires this team of skilled therapists. And I think we've covered from a lot of different countries' perspectives tonight how difficult that sort of thing can be. So I'd like to pose a question to all of you. How would you weigh the risks and benefits of immediate active motion in your setting, or the role of therapists in the immediate post-operative setting? And I'd like to hear first. Maybe we could hear from Linda. Dr. Chikoto, would you mind just commenting? What do you think of this case? What are your first impressions?
Thanks, Kiran. The first impression really is, if you think of early return to work in a society where, for those who are in employment, the majority are in informal sector, meaning that they are only paid when they are physically there. So if you think of that, you would think that, okay, it's quite a great approach. If they can go back to work, they'll be able to earn an income, and then that will reduce the economic losses. And then again, I can only speak for my setting. That's a great approach. But then again, if you weigh the risks associated with that, say for instance, there is a pullout, because we are talking of a situation where most of our patients are not able to see a therapist after operation. So if they start early motion on their own, that's really risky, because if there's a pullout, we have other problems. Theater time is a problem. They may not get another chance to go back to theater and revise the repair. So I really wouldn't offer that to the majority. I wouldn't offer immediate mobilization to the majority of patients. Maybe I would think of offering it to some private patients who would have access to a therapist, timely access to a therapist who would be able to pick up if they are earlier, if there are any problems, because in private practice, theater time is not a big issue as in the public facilities.
Thanks, Linda. Jorge, you presented a case of a tendon repair. Do you have the facilities where you are to do immediate active motion like that? And what's the kind of protocol that you have for patients, the facilities that you have available?
Yes, well, actually where I work, I have the facilities. However, in my country, there is a huge difference between the rural settings and also between the private health system and public health system. So personally, in my setting, I work with a great team of therapists, and we use immediate mobilization. However, there is some cases where you don't have a compliance behavior of the patient, and in those cases, as you mentioned before, the most important is to weigh the risk and benefits of doing early active motion. So I believe that probably in those cases or where you don't have resources or the facilities to do an active motion, probably it's better to go to an immobilization, because I prefer to have an adhesion of the tendon instead of the rupture of the tendon, because in a second stage surgery, tenolysis, after that you can tenolysis, you can use really an active early motion with a minimal risk of complication.
Interesting. It's so, and even in a setting like in Argentina, where you do have the kind of facilities that you work at, you still have to weigh the benefits for every patient individually, recognizing sort of what are the challenges that they may face.
Yes, I think you have to weigh the risk and benefits case by case. Yeah. Not all the patients are the same, and even if you have the facilities, not all the patients are a patient to have in flexor tendon surgery are patient you can indicate active early mobilization.
Yeah. Very important points. Corianne, I'd like maybe if you could make a comment about that. What do you think? Go ahead.
Yes, we all know and have heard so much evidence that early active motion is a very good way of going about it. But it's a very difficult thing to explain to a patient how far and how hard he may move. And if you have a patient who does not understand that, then the protection is actually more important of the surgery, whatever surgery it was, whether it's a tendon transfer or a tendon repair, it doesn't really matter. So we as therapists can actually judge or talk a little bit more with our patients to get an idea about the understanding of what it is that needs to be done. So if that communication between a therapist or a surgeon and the patient is not intensive enough, then we may make the wrong decision and say to somebody, well, you can go and move it. And then they actually have a lot more problems. And I think that if there's a rupture, it is a lot more difficult to fix than actually just a stiff finger after that. I agree very much with Dr. Barreto. I think if we can, in a way, explain to somebody how much they may move and not may move, then but the fact is we have to also get them over that fear of movement, because some of them think it's been surgically fixed and now if I just do this, it's going to tear, and they don't know that as well. So it's a communication story, I think, which is primarily the most important thing. The communication between either a surgeon, if there isn't a therapist, or the therapist and the patient, to understand which way to go. And then a lot of it is also to make sure that the patient understands what he needs to do, because they forget.
Yeah. Well, if I may, Oriane, I think that that's perhaps one of the key things that we can pull away from this, that we, operating here in the United States, can learn from all of you working in these settings. It's the communication is really key. And actually, I'd like to open that question up to everybody. What can hand therapists and surgeons in these resource-rich settings learn from all of you? And maybe, since we're running a little low on time, Audrey, would you like to kick us off maybe with 30 seconds on your take? What would you like those of us who work in a resource-rich setting to take away from the kind of practice that you have? You want to unmute? No, can't hear you. All right, well, while we sort that one out, Hatim, I see your face. Why don't you tell us? What are your thoughts?
Actually, thanks, Kiran, for this. Actually, I don't know what you can learn from our situation, but I think just conclude miracles can happen everywhere.
Mm.
Every time we do surgery, we think that we are not going to make it, and the patient sometimes is so desperate, but we are encouraged with all these outcomes we do see with these all low resources. So let me just get out of this box a little bit and think in another way, how can we all get together as a team so as to present the service for all these countries? I think education is the first step for all of us, and we need a tour to all these countries so as we can serve and we can present our thoughts and we can change the situation. That's.
Thank you, Hatim. Ida, what do you think?
Well, I think the idea scared me a little bit because complications could be really hard. But I think technology is a really, really excellent tool right now. We learned it because the pandemic, the patient cannot get out from home. So we have to teach them what to do it. So we decide to do videos. We do also video callings and show them what was enough to move, how to do it. And I think that's a biggest work for the surgeon and also for the therapist. But I think it's a way to get in touch with the patients. So I will use technology. We are learning because of pandemic, but I think that for the future we will use it a lot.
Yeah, I think we all have learned from your creativity and your resourcefulness. I think that those are really important messages. Marta, I saw your hand go up. Did you have a comment that you wanted to make? What do you think that, what would be your message for us? What can we learn from your work?
Well, I think the first thing I want to say is that as I saw this afternoon, we all have hunger for learning in our countries. So I think this, even if we don't have all the resources, we don't have a high technology, we use a lot of things we have in our daily life. And another thing is, if all the surgeons and all the therapists have the communication that Dr. Boreto and his therapist, because he knows a lot about the stages of therapy. And I was impressed about that, because if a surgeon knows about every stage, every step of the therapy, I am pretty sure that they will send the patients, not right away maybe, but they are going to send the patient very, very soon. And you will know how areas we have to protect and which ones we can set free to move without harming the injury, no? That's my comment. Mhm.
Great point, Marta. Thank you. Audrey, is your microphone working? Did you have any comment that you wanted to make? No, can't hear you. I'm sorry. Oh, there you go. It was there for a minute. All right. Well, Linda, did you have any comments that you wanted to make about this point? You know, what can we learn from the practice that you've had in Malawi?
Thanks, Kiran. I think the main thing for me is for people to appreciate the challenges that low resource countries face when managing some of these problems, where there has been a lot of talk from the high income countries working as a team where you have your therapists at hand, but we are in our setting, we are talking and working in areas where there is no team. It's just you. What do you do? And I'm even thinking of people working in the rural areas where they have very limited training and as far as hand surgery is concerned, but they are faced with a huge number of patients that they have to see and make sure that they have good outcomes. So we really need to think outside the box. Yes, our ultimate aim is to have a team where we can also have everyone who needs to be there for the management of hand cases to be on board. But while we are getting there, we cannot just sit down and say until we get there, then that's when we'll have good outcomes. We need to make sure that we come up with some interventions or some initiatives that are going to help improve hand surgery. So for me, as far as Malawi is concerned, I think the most important thing is to make sure that we train the care providers, both in the rural setting who see the majority of our patients, as well as in the urban setting. Then we have the surgeons and the surgical trainees. We train them. A training has been emphasized in these presentations a lot. We train them so that they are able to provide care, not just clinical care for the patients, but also therapy, because these are the people, in most cases, these are the only people that the patients will meet. Thank you.
That's a really great point, Linda. Thank you for that. So Audrey, sorry that your microphone doesn't work, but I'll read the comment that you wrote. Oh, there you go. Yeah, I can hear you. Yeah, go ahead.
I think my battery died on my AirPods. Sorry about that, guys. My points to take home would be collaboration between team members. Reach out to your tertiary centers if you're stuck in rural like I am. See, so many times there are surgeons that are so willing to use the wheel and spoke method of doing online training, connecting, collaborating, sharing. We have started a small focus group in our province where we do case discussions, we do presentations, and it's all to do with hands, and it is led and it was initiated by a hand surgeon. So that's really nice. It keeps everybody on the same page, and it keeps us on our toes and abreast of what is happening. So I think that's what I would say.
Thanks, Audrey. And you know, the point that I was reminded of in your presentation is as soon as you started increasing the availability of hand surgery and therapy in your hospital, suddenly more patients started showing up. It's the sort of build it and they will come phenomenon, you know? And I think that that's a really, that leads me to the last question that I want to ask in the few seconds we have left here. You know, how can we make care better for everybody by considering care for the poorest? When we start building systems that addresses care for the poorest, suddenly we are elevating the status of care for everybody because we're keeping those patients in mind. So Dr. Mudgal, I think, are we out of time or can everybody have one last few seconds?
I think they can have a last few seconds, certainly.
So shall we start with Corianne? What do you think? How have you seen that be the case in South Africa?
Oh yes, very definitely. The more you can offer people, the more people come. And word of mouth is very good. There's an idea that people can be helped, and I think that's a great way of doing it. I was thinking that one of the things I could do is go and visit Malawi, Linda. You must invite me, and then I can come and visit and maybe spend some time with your healthcare workers. And in that way, we have a better collaboration.
That's great. Marta, what about you?
Well, I think my final thoughts are about the communication we have to have with between the surgeon, the therapist, and try to use everything we have to work. Try to learn all the time. We have the chance to see in stages of the hospitals or schools, or we have, as doctor said before, we have the chance to ask the therapist who know more about a topic we want or a patient we have the chance to talk about that, send a video or have a video chat to have for this patient a better treatment.
Thanks, Martha. Ida, I see you next on the screen for me. What are your thoughts?
Well, I believe that as a surgeon, I have a really big social responsibility. So that's what I'm trying to work with the society to get closer to the poor population. In this case, I'm focusing kids, trying to do free surgery for them. It's not easy because we have to work with donations and to get the money for these kind of missions, but we have to work for our population and also work for education. I think that that's the main point. If we try to train or educate our therapists and also our youngest surgeons, we will get better results.
Thanks, Ida. Jorge, what do you think?
Well, I think that one of the most important things to get the best result in hand surgery is to work as a team with the therapist. I think that is the most important thing. No matter the setting you work, if rural or if in a big city, the most important is to work as a team. Hopefully, when you work, probably when you work in a low income country, the hand surgery is not like a reconstructive hip or knee surgery when you need expensive prosthesis. So probably we face this complex problem with as Adri show us with a low or not expensive material to work with. So I think that we have a great opportunity to get a great care in terms of our specialty. So for me, the most important is to work as a team, and as Ida said and Hatim said also, the most important to have a good care is about the education of hand surgeons and hand therapists.
Thanks, Jorge. Great point. Hatim, 15 seconds we have right now. Do you have a final thought?
Okay, maybe I just want to say, if you work in some countries, you can see all your dreams come true with time. People will get more encouraged and you will invite them to create more and more effort in order to help those people. And I have no doubt that we are going, all of us, to make it one day. So education will be the cornerstone for all of us, and teamwork also. Thank you.
Thank you, Hatim. Thank you all so much. Dr. Mudgal, I'll let you take us out.
Thanks very much, Kira and Becky. That was a fantastic session. To all our panelists, I owe a big thank you. Sharon Wong asked a question. Does AO have any idea about or any plans to connect therapists from here to therapists other parts of the world? And that she would love to be a part of this. Sharon, this is a direct answer to you. I'm not one for quoting scripture, but I believe in Luke 12, chapter 12, verse 48, to whom much has been given, from them much is expected. So with that being said, I promise you that AO North America's Hand Education Committee will explore this Chitra, our Chief Learning Officer, is on this call. And I hope you're listening, Chitra. We'll be talking about this and hopefully we'll be able to set this up. So that being said, thank you to my co-chair, Becky. Kiran, Becky, wonderful job. All the panelists who came today, to all our faculty who have done such spectacular work over the last 15 months, to AONA staff, and to all our attendees without whom we would not be doing this. We've had nearly 2,000 attendees over the last 7 sessions. Kiran, good luck on your fellowship. I know you're rotating off the committee. It's been a joy to have you. Tom Hunt has also been rotating off the committee. Thank you, Tom. The summer will be taking off. I think all of us need a little bit of a break. So we'll be resuming activities after Labor Day and with the AONA Masterclass. And that is going to be awesome. I can promise you that much. With that being said, thank you, everyone. Be safe, be healthy. Good night.